Good afternoon, and welcome to Microsurgical Treatment of Geniculate Neuralgia, featuring Dr. Mark Linsky. I'm Brandy Underwood, the Manager of Development, Research, and Advocacy for the Facial Pain Association. Before we begin, I want to go over a few housekeeping items. On your screen, you should see an option for both Q&A and chat. We encourage you to connect with other attendees using the chat feature. Please reserve the Q&A for your questions, and we'll get to as many as we can following the presentation. I plan to monitor both, but using the designated option will hopefully allow us to get to more of your questions. Although presenters today may be doctors, they are not serving as your doctor during the Q&A and are unable to answer questions about your specific health situation. We request that you keep your questions general in nature, and we will do our best to select questions that will benefit most people living with facial pain. Now, it is my pleasure to introduce Dr. Mark Linsky, a professor of neurosurgery at the University of California, Irvine, and a member of the FPA Medical Advisory Board. His clinical interests encompass brain and spine tumors, cranial nerve disorders, gamma knife stereotactic radiosurgery, trigeminal neuralgia, glossopharyngeal neuralgia, hemifacial spasm, skull-base microsurgery, and microvascular decompression surgery. Dr. Linsky has also authored or co-authored more than 100 peer-reviewed articles. Dr. Linsky, it is an honor to have you with us today. Please take it away.
Well, thank you very much, Brandy. It's a pleasure to be here this afternoon with everybody. I thank you for attending. My name is, as Brandy said, is Mark Linsky. I'm a neurosurgeon. I practice at the University of California, Irvine in Orange County, California, which is the area of Southern California between San Diego and Los Angeles. I've been asked today to talk about geniculate neuralgia and the surgery for that. And quite frankly, it's an area that is very poorly understood and very poorly characterized. So it's a real pleasure to talk about it and to try to bring some clarity to the issues surrounding it. When the Trigeminal Neuralgia Association, formerly known as TNA, became the Facial Pain Association, the mission expanded enormously. It exploded. So now, instead of just taking care of and trying to educate and help patients and families with trigeminal neuralgia, we're now talking about post-herpetic neuralgia, post-traumatic neuralgias, trigeminal autonomic cephalgias, but also facial pain syndromes that don't necessarily involve the trigeminal nerve. So glossopharyngeal neuralgia, which is a rarer form of cranial nerve disorder. But geniculate neuralgia has always been kind of the poor adopted stepson because it's difficult for both physicians, surgeons, and patients. It's much more complex. And I think we're going to be able to show you this today. So let me see if I can, Brandy, my slide is not advancing. There we go. All right. So I do have some disclosures. I'm the Western Regional Director of the Medical Advisory Board of the FPA, and I'm also the faculty advisor for the Orange County FPA support group, but neither of these are paid positions. So there's no financial conflict of interest here. So what are we talking about when we talk about geniculate neuralgia? Well, it is actually sudden, brief, severe, episodic, deep ear pain, not just ear pain. Deep ear pain. And it has many names, and that is where a lot of the confusion begins. So it can be called geniculate neuralgia, it can be called Hunt's neuralgia, nervus intermedius neuralgia, intermediate nerve neuralgia, paroxysmal otalgia, episodic otalgia, and primary otalgia. And each of these names are horrible for various reasons. None of them are truly accurate or encompass all of what this syndrome is. When you have episodic deep ear pain, you have to first make sure you're not dealing with a condition that has nothing to do with cranial nerves. because then you're going to be barking up the wrong tree and pursuing wrong procedures to try and intervene. So we talk about a differential diagnosis. What else can cause primary episodic deep ear pain? Well, one of the conditions that can do so are temporal mandibular joint disorders, or TMJ. And this is basically degenerative disc disease of your TMJ joint with internal joint derangement and myofascial pain of the system around it. It's diagnosed by TMJ imaging, and the patient will often have a click when they move their jaw on examination. You can also have eustachian tube dysfunction cause deep episodic ear pain. Failure to equilibrate the pressure on both sides of the eardrum, because the eustachian tube, which allows the pressure to equalize behind the eardrum in the middle ear, is having dysfunction. You can also have a viral syndrome known as herpes zoster oticus, or Ramsay-Hunt syndrome. And this is a viral ganglionitis of the geniculate ganglion, and it affects the external auditory canal, or the temporomandibular membrane, with eruptions of vesicles, just as if you had a herpes outbreak or a shingles outbreak elsewhere on your face. In this condition, the trigeminal nerve, the geniculate nerve, the facial nerve, and its ganglion, the geniculate ganglion, can enhance on MRI. And this is where the term geniculate neuralgia came from. But what we're talking about as geniculate neuralgia has nothing to do with the virus. Also, you can have infections cause episodic deep ear pain. Infections of your middle ear, otitis media, and infections of your external ear, otitis externa. And it's very important to have a proper, thorough neuro-otologic evaluation through an ENT neuro-otologist looking at this with you as part of your multidisciplinary team to make sure you're not missing one of these other syndromes. Now, geniculate neuralgia is considered extremely rare, and that may not be correct. Trigeminal neuralgia, which is the most common of the cranial nerve pain disorders, has an incidence of 6 per 100,000 per year in women, which is in women it's 2.5 times more common than men. And this is considered an orphan syndrome, and this is the most common of the cranial nerve syndromes. It is 8 times more common than hemifacial spasm, which has an annual incidence of 0.78 patients per 100,000 population per year. And hemifacial spasm is 1.5 times more common than glossopharyngeal neuralgia, which is considered rarer than hemifacial spasm and doesn't have very good epidemiology independent figures. But geniculate neuralgia is considered the rarest of them all. It's often talked about as a distant fourth, if it's even talked about at all, and there are no good epidemiology figures for it. Well, as I just foreshadowed, this may not be true. If you look at my experience operating on cranial nerve pain disorders for over 19 years at the University of California, Irvine, from April 2004 to April 2023, just a year ago, we did 614 MBDs for trigeminal neuralgia. We did 79 for hemifacial spasm, which means trigeminal neuralgia was 7.8 times more common in our practice, which is very close to the 7 times more common than you have in the literature. And for glossopharyngeal neuralgia, we did 57 MBDs, with glossopharyngeal neuralgia being 1.4 times less common than hemifacial spasm, very close to the 1.5 times less common the literature would suggest. But what about geniculate neuralgia? For geniculate neuralgia, during the same time period, we did 143 MBDs. In fact, in our practice, it was 1.8 times more common than hemifacial spasm. So instead of being number 4, at least in our practice, it's number 2, and therefore needs to be addressed. And there's a real paucity of information out there that we're trying to help with this presentation today. Now, one could argue that maybe this is a statistical bias, an aberration based on referral pattern. And there's some reasonable argument to that. If you look at my practice for those cases, only 19.8% of them came from the 6-county Southern California area. 80% came from out of the 6-county California area, and 76% came from out of state or out of the country. And you can see where the patients came from on the map that's displayed here. So it's certainly possible that my practice is skewed by a referral bias, but I don't think it's going to be skewed by all that much. I think there's a huge gap of distance between geniculate neuralgia and hemifacial spasm to where geniculate neuralgia would still probably remain number 2. Now, geniculate neuralgia is different. In our 116 patients, it is very rare for geniculate neuralgia to present as the only form of pain. Only 7% of patients, 8 patients, had just geniculate neuralgia and not something else along with it. 44% had geniculate neuralgia as their dominant syndrome, but with a combination of other cranial nerve pain syndromes, most commonly trigeminal neuralgia, but also glossopharyngeal neuralgia. And you can see the number breakdown in terms of how that turns out. But that means that it's only 51% of patients where it's either geniculate neuralgia alone or geniculate neuralgia dominant. The remaining 49%, geniculate neuralgia is a minority syndrome with a combination of other cranial nerve syndromes, and most commonly with trigeminal neuralgia. And unfortunately, I think that part of the reason that it's so underrepresented and so underrecognized is because doctors who treat patients with trigeminal neuralgia don't ask about it. They don't know about it. They're confused by it. They don't even ask the patient about it. In fact, many of my patients that I evaluate for trigeminal neuralgia or glossopharyngeal neuralgia are surprised that I ask them about it, and they come forward with that information for the very first time to a provider. In our 116 patients, the onset of cranial nerve pain was geniculate neuralgia in only 45 of them, 38.8%. In 31%, 36 patients, only geniculate neuralgia was the onset, but in 4, it was simultaneous onset with TN, 4, it was simultaneous onset with glossopharyngeal neuralgia, and in 1 patient, simultaneous onset of all 3. In 64.4%, geniculate neuralgia remained the dominant cranial nerve syndrome within an eventual combination syndrome. And in 35.6%, patients went on to develop a geniculate neuralgia minority syndrome within an eventual combination syndrome. One thing I want everybody to take home from this talk today is that geniculate neuralgia is not trigeminal neuralgia of the ear. You can't consider geniculate neuralgia as trigeminal neuralgia by analogy. There are huge differences. The median age of onset for trigeminal neuralgia is age 61. The median age for geniculate neuralgia is 41 in our series, with a range of age 10 to age 80. 13 of our patients were less than age 18, 17 less than age 21, which means that we're talking about 30 patients that were pediatric. 40% had the development of the syndrome before age 41. 31 patients had the onset after age 50, but only 11.2% had the onset after age 60, whereas after age 60 for onset is the case for 50% of patients with trigeminal neuralgia. Trigeminal neuralgia is dominant female to male by 2.5, but that's nothing compared to the female dominance for geniculate neuralgia. 89.7% of our patients are women or young ladies. So it's 8.7 times more common in women than men, as opposed to 2.5 times more common for trigeminal neuralgia. 40.5%, 47 patients had bilateral geniculate neuralgia versus less than 5% of patients greater than age 50 with trigeminal neuralgia. In fact, 40 presented to us with bilateral geniculate neuralgia. Of those 40, 17 had bilateral MVDs as their operation. 23 have had only one side done, but we're looking to do the other side at some point in the future as they recover. 7 presented to us as unilateral geniculate neuralgia, but then during their follow-up went on to develop bilaterality with onset of the syndrome on the other side. So bilaterality is very common with geniculate neuralgia, whereas it's rare except for the pediatric subset for trigeminal neuralgia. 93.1% of patients had their geniculate neuralgia not in isolation, but in combination with either trigeminal neuralgia, glossopharyngeal neuralgia, or both. Once again, geniculate neuralgia is not trigeminal neuralgia of the ear. It's a different animal. I don't want to get too detailed, but you need to understand a little bit about the anatomy of the ear if you want to understand geniculate neuralgia. The adult ear has 3 parts. The external ear, which includes our external part that we can see, canal all the way into the outside lining of the temporomandibular, of the tympanic membrane. The middle ear is on the other side of the tympanic membrane. It is the air space between the tympanic membrane and the temporal bone inner ear structures. It contains the ossicles that vibrate to create sound. It is connected to the eustachian tube, which connects to the back of our throat to equilibrate air pressure in the middle ear. And then the inner ear is the sensory organs of the ear, the vestibule, cochlea, and semicircular canal, and those are within the temporal bone itself. Now, the development of the ear embryologically is extremely complex. I don't have enough time to go into it here, and I don't think anybody would really appreciate that sort of a lecture. It's really technical and it's really complicated. But due to the complexity of embryologic development, the corollary, the bottom line, is that 4 different cranial nerves can mediate ear pain. Not one. 1 for trigeminal neuralgia, 2 for glossopharyngeal neuralgia, 4 for geniculate neuralgia. This includes the trigeminal nerve, cranial nerve 5, via the auriculotemporal branch, the facial nerve, cranial nerve 7, via a twig, a small twig of the facial nerve called nervus intermedius. The facial nerve, 95% of it gives motor innervation to the muscles of our face. But that a twig called nervus intermedius carries 3 things: somatic innervation to the eardrum and external canal, autonomic innervation to our tear gland, the lacrimal gland for tearing, as well as special sensory taste to the front half of our tongue. Those 3 things go through nervus intermedius, which is separate from the motor part of the facial nerve. The glossopharyngeal nerve, cranial nerve 9, contributes to the ear sensation via Jacobson's nerve. It has a contribution to the auricular branch of the vagus nerve, otherwise known as Arnold's nerve, as well as the tympanic nerve plexus, also known as the tympanic nerve of Jacobson. And a lot of these things have multiple names, which can make things even more confusing. The vagus nerve, cranial nerve 10, gives innervation to sensation to the ear via Arnold's nerve, also known as the auricular branch of that nerve. So here's a picture showing you where the auriculotemporal nerve is. It's a branch of the trigeminal nerve, and it comes out. Can you see my cursor here? It comes out at foramen ovale and runs behind and underneath the temporomandibular joint, and then comes out to the surface of the ear and the scalp, involving the anterior and upper part of the ear. Nervus intermedius is shown here. It's also known as the nerve of Riskberg, after Heinrich Riskberg, who described it in 1777. I've already mentioned what its components are in terms of what it carries. This is a picture of it on the top in a cadaver, showing the 7th motor nerve, the 8th cochlear and vestibular nerve, and the nervus intermedius with the brain removed, and just showing you as it goes out towards the skull in the internal auditory canal. This is a microscopic picture from one of my patients showing the 7th and 8th cranial nerve right here, and nervus intermedius being dissected away from it and held away in preparation for sectioning. It's identifiable as a separate nerve in only 80% of cases. In 20%, it's actually fused to the vestibular nerve until it gets out to the internal auditory canal and can't be separated from either the 7th nerve or the vestibular nerve. And here's another important point. It's usually a single fascicle, but rarely can be multiple fascicles, up to 2 to 5. And this is very well described. So you can go to a surgeon and have your nervus intermedius sectioned for geniculate neuralgia, and if you still have geniculate neuralgia afterwards, one of the questions has to be, did the twig they cut, was that all of the nervus intermedius, or were there other twigs that were missed? And so oftentimes we have to test. So how do we test? The test is called a Schirmer's test, named after Otto Schirmer. And what we do, it's a very simple test. You put a little dye drop in the eye so that the tears will have dye in it, usually fluorescein, and then you make a little candy cane hook out of a piece of filter paper, and you hook it under the lower eyelid, and you have the patient close their eyes. And then it just acts like a paper chromatography. The tears travel down the paper via capillary action, and you measure how far they get over a certain amount of time, usually 5 minutes. And normal is to travel 10 to 15 millimeters, abnormal less than 5 millimeters, less than or equal to 5. So if the Schirmer's test shows it's traveling more than 5 millimeters, or it's traveling the same as the other side after supposedly having nervus intermedius sectioned, well, then the whole thing hasn't been sectioned because the nervus intermedius is still working. Now, this is just a diagram showing you how Jacobson nerve gets to the ear, also known giving a contribution to the auricular branch of the vagus nerve from the lower ganglion of cranial nerve 9 going up into the temporal bone. And this is another picture of it, a little more anatomically, a little less cartoonish here on the right. And then this is the same thing for Arnold's nerve, the auricular branch of the vagal nerve coming from the upper ganglion of the vagus nerve in the jugular foramen to enter the temporal bone. And this is a schematic drawing of that same thing, with a little more anatomically correct to give you an idea of where that nerve contribution is coming. So when we talk about the complexity of innervation to the external ear, you have to recognize it's 4 cranial nerves. Now, this is a cutaway of the ear looking at it from the outside from the front. So in this situation, the auricular branch of the vagus nerve is purple, the facial nerve via nervus intermedius is yellow, and the auriculotemporal branch of the trigeminal nerve is green. So you can see that the superior and what would have been anterior, but it's cut off, of the auricle is trigeminal nerve, but it also has some innervation all the way to the eardrum. But you also have cranial nerve 7 and cranial nerve 10 innervating within the ear canal externally. And then if you look at this from behind, the color scheme's a little different. There's a little area on the back of the ear where it meets the scalp, which is cranial nerve 7 via nervus intermedius and cranial nerve 10. So now you can see why 4 cranial nerves can contribute to this problem. Now, it's even more complex when you look at the eardrum itself, the tympanic membrane. This is giving you an otoscope view, looking into somebody's ear, with over here on the right being anterior and over here on the left being posterior. The external surface of the eardrum anteriorly is cranial nerve 5 via the auriculotemporal branch. The posterior superior surface of the eardrum is cranial nerve 7 via nervus intermedius, and the posterior inferior portion of the eardrum on the outside is the auricular branch of the vagus nerve, Arnold's nerve, which is cranial nerve 10. So for the outside surface of the eardrum, 3 nerves. Now, this is a cartoon, and you can forget about this part. We've already talked about it. This is the external ear, and this is the external canal. But what's in green here is the middle ear. Now, what's in green here is cranial nerve 9 innervation, which is the inner surface of the eardrum, the whole lining of the middle ear, and the upper 2/3 lining of the eustachian tube going down towards the throat. That's cranial nerve 9. So now you have a good idea of why ear sensation and therefore ear pain can be mediated by 4 cranial nerves, not just 1. Now, when I see patients and talk about neuralgic pain, I spend a lot of time talking to them about typical versus atypical neuralgic pain. And this is really important for practical, pragmatic, predictable purposes. Typical neuralgic pain is sudden, sharp stabbing and electric. It's immediate full force at onset. There's no ramp up period. It's brief. It lasts seconds or minutes. It has immediate resolution, no ramp down period. There's no pain between episodes. Patients often refer to these as attacks. They're often triggerable, and they're the most likely to initially respond completely to initial treatment with anticonvulsant therapy. So if you drew this for the patient, this would be the bottom pain-free. This is the pain episode, pain-free, pain episode. But sometimes the patient will tell you, well, my pain lasts more than seconds to minutes. It lasts longer than that. And there you've got to distinguish between it coming on and lasting the whole time and coming off versus stacking short, brief stabs one after another. This is still typical neuralgic pain if it's a stacking phenomenon. The other type of pain is atypical neuralgic pain, which has a much broader descriptive phenotype. It's described by the patient as dull, aching, throbbing, pressure, or burning pain. It can be episodic, meaning no pain between episodes, but these episodes tend to last minutes to hours rather than seconds to minutes, and they can have ramp up or ramp down periods, as you see in this diagram here. But they also can be constant, either at a steady level or at a steady low background level with episodic flares. And they often, while they may respond to anticonvulsants, they usually respond incompletely, meaning partially. It improves things, but doesn't completely take it away. Now, why is this important? Because pain, particularly over time with cranial nerve syndromes, falls on a spectrum. All the way over here on the left, 100% typical neuralgic pain. Over here on the right, 100% atypical neuralgic pain. And classical or typical cranial nerve pain syndromes are 100% typical neuralgic pain. That's true for trigeminal neuralgia, glossopharyngeal neuralgia, or geniculate neuralgia. Over here, 100% atypical neuralgic pain, which can be episodic, constant, or constant with low-level background with episodic flares. But then you have two syndromes in the middle that are intermediate, that are hybrid syndromes. In our clinic, we don't call classic typical trigeminal neuralgia TN1. We only call it TN1 if both types of pain are present, but the typical neuralgic pain dominates. We don't call patients with atypical neuralgic pain only TN2. We only call them TN2 or GN2 in this case if they have a hybrid syndrome where the atypical is more than 50%. Now, why is this so important? Well, because we use different endpoints for measuring surgical success and setting realistic expectations after surgery. For typical neuralgic pain, the endpoint to measure success is very black and white, being pain-free. For atypical neuralgic pain, we don't use that endpoint because it's unrealistic. It's not the one that's most commonly achieved. For atypical neuralgic pain, we use the endpoint we use for clinical drug trials for trigeminal neuralgia, namely a 50% improvement in the frequency and severity of the pain, taking it to a 5 out of 10 or less in frequency and severity compared with 10 out of 10 prior to the procedure. And I already mentioned this is the endpoint for drug trials. Now, surgery for geniculate neuralgia has a history behind it. It was first performed, believe it or not, under the direction of a neurologist, Alfred Taylor in New York City. This was back in 1909. And in those days, neurosurgery was not a separate specialty. Neurologists teamed up with general surgeons and told them what they wanted to have done. And so Dr. Taylor thought that maybe geniculate neuralgia or deep ear pain could be via the geniculate ganglion, because the geniculate ganglion gave pain after viral infections of the geniculate ganglion. So he had Dr. Clark take out the geniculate ganglion, and that was the first successful surgery for geniculate neuralgia. Ernest Sachs, chairman of neurosurgery at Dartmouth, was the first to really focus on farther closer to the brain, the role of nervus intermedius, which gives the innervation to the geniculate ganglion. And he reported 4 cases of sectioning nervus intermedius. Now notice this is 1968. He did this before the surgical microscope. So for somebody to be going to the posterior fossa, identifying nervus intermedius and sectioning it without causing facial paralysis or deafness was really, really an amazing thing, and took a tremendous amount of courage and a lot of skill. Jack Pulak is an ENT neurotologist, first trained at House Clinic and then went to Mayo Clinic and then back to LA for private practice. And he went back from the ENT perspective at targeting the geniculate ganglion because they could target that through a middle cranial fossa approach rather than through a craniotomy approach in the posterior fossa. John Tu, who is a former medical advisory board member for the FPA, TNA, was the first to do MVD for this. He happened to be doing MVD for a patient who had hemifacial spasm, but also had geniculate neuralgia. He was doing the MVD of cranial nerve 7 for the hemifacial spasm, but was amazed when the patient woke up free of geniculate neuralgia as well. And he published this as the first MVD ever done for geniculate neuralgia. And then Peter Janetta, my mentor and chairman who trained me for 7 years, was the first to focus on all 4 cranial nerves with microvascular decompression. And this was back in 1997, but unfortunately he died before the larger series and longer follow-up could ever be analyzed or published. Now, the reason that so many patients with geniculate neuralgia have trouble finding information about it is because there's very, very little bit published. Up until May 2023, which is less than a year ago, there are less than 180 reported cases in the medical literature. And I mean the whole medical literature. These consisted of 25 case reports and 155 cases in 10 series. These series had 3 to 65 cases, each over many years. The largest series was 65 patients, but it was only a 3-page publication, so very limited amount of data and outcome analysis possible. The remaining 9 series had only 3 to 18 patients each. And these are those series. So here's 18, here's 64, the rest are 14, 12, etc. This is the OHSU experience with Dr. Burchell, where all they did was section nervus intermedius, and you will notice that they only had an excellent result in 58% of patients. If you look at the larger other series, this is Dartmouth's update from Sachs, where they had 18 patients, but notice they did 31 operations. Or Pulak, where he went from 15 to 64 patients, but notice they did 90 operations. Sectioning nervus intermedius was not enough. They had to go back and do additional operations in many, many of their cases to be able to get reasonable results. In fact, in Pulak's original article, he only did partial ganglionectomy only. By his 2002 update, he did 90 operations for 64. 29% required additional operations for cranial nerve 5, 9, or 10, involving either partial or complete nerve sections to get those good results. With Dartmouth, the original publication by Dr. Sachs, 4 cases, nervus intermedius alone. The 1991 update, 40% required additional operations for cranial nerves 5, 9, or 10, either MBDs or partial or complete nerve sections. So the next take-home point from this talk is that for geniculate neuralgia, addressing nervus intermedius alone is not enough. Now, our series over 19 years is listed here. We have 116 patients with 143 operations. This is twice the size of the next largest series ever published. 89 of these operations were first-time retrosigmoid craniectomy, so that's 62.2%. 54 were re-explorations, 37.8%. 9 of these 54 were my own re-exploration, 5 in patients who went on to develop GN after their first operation, which was at that time only for trigeminal neuralgia. So it wasn't that we missed it or didn't appreciate it or try to treat it. It just wasn't there at their first operation. And 4 for failure of first OR to adequately address their GN, only 4. The other 45, the first retrosigmoid craniectomies were done elsewhere. And these are the breakdown of where they were done. In only 9 out of 45 did they have prior surgery for geniculate neuralgia, and the other 80%, despite in retrospect when questioning the patient, geniculate neuralgia being present at the time of their first operation elsewhere, only an MBD of cranial nerve 5 was attempted. And you can see that these are some of the most well-known centers in the United States for treating cranial nerve pain syndromes. So even some of the best surgeons in the US are not appreciating geniculate neuralgia. They're not asking about it, or if they are asking about it and appreciating it, they're not knowing what to do with it. And so they're leaving it alone and hoping it just goes away when they operate on the other dominant condition. For those 9 that had prior surgery for geniculate neuralgia, 4 had prior section of nervus intermedius, 5 had MBDs, either for cranial nerve 5 or 7, 9 or 10, 5, 9, and 10, 7, 9, and 10, but only 1 for all 4 cranial nerves. Now, in our operative cases of 143, 80 were on the left, 63 on the right, so it was more common on the left. The geniculate neuralgia syndromes, 51% were classic geniculate neuralgia, 100% typical neuralgic pain only. 28% were a TN or a GN hybrid syndrome type 1, more than 50% typical. 16 or 11.2% hybrid syndrome type 2, more than 50% atypical. And only 14, less than 10%, were 100% atypical neuralgic pain. Interestingly, there are other unusual associated cranial nerve syndromes with this, which also emphasized the fact that there's more than one cranial nerve that could potentially be involved. So 8 had episodic hoarseness, spasmodic dysphonia, or ipsilateral hemivocal cord spasms, which is cranial nerve 10. 3 had ipsilateral hemifacial spasm, which is cranial nerve 7. 3 had ipsilateral tinnitus, which is cranial nerve 8. 2 had palatal myoclonus, which is cranial nerve 9. And 2 had neurogenic coughing, choking fits, which is cranial nerve 9 or 10. We're not sure. Of those 143 cases, 89.5% were sudden onset neuralgic pain. In 86.7%, it was what we would call memorable onset. That doesn't mean that they remember the exact date or time or year that it happened, but they can tell you exactly what were the circumstances, what was going on when they first felt it, because it's so sudden, startling, and severe that it sears itself in their memory. 93% had initial anticonvulsant responsiveness. 55.9% had triggers for their pain episodes, and this was very interesting. In 39, swallowing was the trigger, suggesting cranial nerve 9 and 10. In 21, loud noise vibrating their eardrum was the trigger. That could be any one of the four. In 19, it was earbuds or a hearing aid, and that could be any one of the four. In 13, it was touch or pressure or wind on the auricle, which could be cranial nerves 5, 7, or 10. In 13, it was cold or hot drinks or liquid. 7, using a Q-tip in the external ear. 4, brought on by singing, talking, or laughing. And 1 with barometric pressure changes. Symptom duration was a median of 33 months, a little less than 3 years, with a range of 4 months to 30 years. A quarter had less than 15 months onset duration before coming to see us. In 50%, it was less than 2 years or 9 months, and only in 10% was it more than 10 years. All our patients are very carefully worked up. They get a full neurosurgical evaluation. They get a neurotology evaluation when the diagnosis is uncertain and they live locally. We use other neurotologists elsewhere where they live for our traveling patients. Our pediatric patients are all evaluated by pediatric neurosurgery and pediatric neurology to make sure we're not missing something. They all go through preoperative baseline testing with audiogram and ABR, eighth nerve testing, direct laryngoscopy evaluation for their vocal cords, formal speech therapy swallow evaluation, and barium sine swallow study. We need objective evidence of how cranial nerves 8, 9, and 10 are functioning before we do this surgery to make sure that if there are any problems afterwards, that we can measure whether there's been a change and we can follow their recovery. The surgery is done just like any other microvascular decompression, lateral park bench positioning. In this case, we monitor many cranial nerves. We monitor the eighth nerve through auditory brainstem evoked response, facial nerve with EMG, glossopharyngeal nerve with electrodes put in the soft palate, vagal nerve with an endotracheal tube with electrodes at the vocal cords. We test the nerves with stimulation at surgery, both before and after manipulation and decompression. They spend 1 night in the ICU with neuromonitoring, kept NPO with Q1 hour neurochecks. The next morning, they go through a formal bedside swallow evaluation before we let them eat a safe diet. And then we begin aggressive mobilization day 1. The median length of stay in the hospital is 3 days, with greater than 90% of patients being discharged by day 4. So what did we find? Well, there were 0 negative explorations. All cranial nerves were anatomically intact at the end of each case. All motor cranial nerves electrically stimulated at the end of the case. The observations at surgery was that there was most often no change in stimulation threshold pre and post decompression, but they were almost as likely to have improvement in stimulation as elevation. And we even had several cases where cranial nerve 9 did not stimulate pre-decompression, but then did after decompression. We had no even temporary cranial nerve deficit if stimulation threshold improved post-decompression. Increases in stimulation threshold when present after decompression were usually very small. And we also found that cranial nerve 9 responses in the levator palatini and the soft palate were seen with stimulation of cranial nerve 9 as well as with stimulation of upper fascicles of cranial nerve 10, which just goes to show you that levator palatini can have both cranial nerves innervated. In terms of clinical outcome, we followed them on a prospective protocol, follow-up and examination at 2 weeks, 3 months, 1 year, and then annually. Our follow-up range was between 2 weeks and 10 years for the ones I'm reporting today, with a median follow-up of 13 months, 42% more than 2 years, 25% greater than 3.5. We had a real problem with the COVID pandemic issues, which was 3 years, 3 months out of our 10-year, 10-month follow-up period. Many of our out-of-state patients would not travel for their follow-up due to fear of contagion or travel restrictions. And so our median follow-up, if COVID had not occurred, would have been 3 to 4 years for this series. And we're still in the process of catching all those patients up, which hopefully we will do. What were our goals going into this? What were we trying to achieve? Well, a lot of them were based on what were the results achievable with trigeminal neuralgia. So for typical neuralgic pain, we wanted to hit 70 to 80% of patients at follow-up, not just initially, but at follow-up, being completely pain-free. 0 out of 10 on a 0 out of 10 rated scale. For atypical neuralgic patients, as previously stated, the target was to be less than or equal to 5 out of 10 on a 10 out of 10 frequency and severity scale, so greater than or equal to 50% improved. So here are the results, and this is a complicated table, but it's divided into typical neuralgic pain at the top, atypical at the bottom, immediate and then last follow-up, and it's divided into different subsets of patients, the overall series, first-time retrosigmoid craniectomy, and re-explorations. You can see right off that we exceeded our expectations for atypical neuralgic pain. 62.7% were improved, 64.4% were improved more than 50%, and we even had almost 40% pain-free. So it doesn't mean that with atypical neuralgic pain you can't be pain-free. That's just not the main chance. But we weren't as happy with our typical neuralgic pain, where we thought we would be the best. We had 86.1% improved, but only 52.7% pain-free. Even for the first-time MBDs, only 54.3% were pain-free. We also looked at other subsets to see whether somebody who had glossopharyngeal neuralgia might do better, and they did. We have 71.4% pain-free here. But then we went through an evolution in our philosophy and looked at the difference in outcomes before and after this change. So between June and December 2012 to 2019, which is the first 7 years, 6 months of this series, we were following a Geneta purist approach. Do not damage any cranial nerve if you can help it. Only do MVDs, not nerve sectioning, cranial nerves 5, 7, 9, and 10. There were 2 exceptions. For a redo where there was scar tissue in the posterior fossa and on the cranial nerves, we would section nervus intermedius. And in the cases where there was a blood vessel going between the nerves, such as an artery here or a vein here, we would, because we can't adequately decompress those vessels, we would sacrifice nervus intermedius. But then for the last 3 years, 5 months, we switched to, in addition to doing microvascular decompression, cranial nerves 5, 7, 9, and 10, sectioning nervus intermedius if it can be found at the first operation. So why did we change? Well, we found difficulty in consistently finding nervus intermedius and re-explorations, because even if the nerve was separatable at the first operation, which we weren't present, once scar tissue developed, it became increasingly difficult to separate it without causing risk of other cranial nerve problems. I also had difficulty finding nervus intermedius on my 4 personal redos after GN failure, where I didn't section it at the first operation. And we wanted to avoid the morbidity of re-exploration, because re-exploration surgeries, particularly for 4 cranial nerves, are much more daunting and much more difficult. We also noted the small magnitude, the relatively minor symptom deficits produced by nervus intermediate section. In most cases, it's not a major issue for patients from their perspective, unless they live in a dry desert environment where hydration to the eye has to be very carefully looked after with eye drops. We did not make this change in a desire to improve outcomes. In fact, we hadn't done an interim analysis at the time we did this change. But what did it show? Well, if we look at those where we section nervus intermedius in addition to MVD of all 4 cranial nerves, we're now getting to where we want to be. We now have 69.2% pain-free with typical neuralgic pain. We have 69.2%, at least 50% improved for the atypical neuralgic pain compared to the earlier results that I've already mentioned to you. So clearly, this is the paradigm that works the best. Our cranial nerve complications and other complications were relatively low. The most common were temporary dysphagia and swallowing dysfunction and temporary hoarseness, which did not persist. The nerves recovered just fine. The unexpected thing compared to our other cranial nerve MVDs was a higher rate of problems with double vision, but again, very temporary. We did not have major problems with some of the other things that we were worried about, such as needing laryngoplasty, vocal cord medialization, gastrostomy tube, or tracheostomy. No patient required tracheostomy, and only 1 required a gastrostomy tube. So in summary, But I want you to take away from this, if you've heard nothing else, or if you're falling asleep, wake up and listen to this. Geniculate neuralgia is not trigeminal neuralgia of the ear. It has significant differences. It rarely presents in isolation, only 6.9%, whereas the other ones usually do present in isolation. About 50% of the time, it's a minor component of a multiple cranial nerve pain syndrome patient situation. It is more often bilateral, 40.5% versus 5% in older TN patients. It is an even greater female preponderance than trigeminal neuralgia. It may be more common than we think. Why? Because it's often not asked about or recognized by the physician. It may not be the major pain syndrome component of the patient's complaint, and they may be focusing on the major component themselves. The patient may not have ever heard of it, and the surgeon may not feel comfortable operating on this cranial nerve syndrome because they may have potentially less training or experience with it, and they may be daunted about doing a forecranial nerve posterior fossa exploration. Given the sensory anatomy and innervation of the ear, optimal surgical treatment requires addressing potential contributions from all four cranial nerves: cranial nerve 5, 7 via nervus intermedius, cranial nerve 9, and cranial nerve 10. Addressing nervus intermedius alone is not sufficient. It has a higher rate of long-term failure. MVDs of cranial nerves 5, 7, 9, and 10 with section of nervus intermedius may provide the best results for patients suffering with this condition. Our data certainly support that. This involves simultaneously forecranial nerve microsurgery. This potentially carries a greater risk for your patient. So obviously the surgeon involved has to be extremely experienced and well-trained, not just in single nerve or two nerve MVDs. However, with the proper training and experience and a thorough cranial nerve neurophysiologic monitoring, it can actually be performed with an excellent safety profile, as we've shown. Now, obviously, forecranial nerve microsurgery involves a whole team to put this together. This up here on the left is Sunil Verma, the laryngologist who sees all my patients and examines their vocal cords preoperatively and helps us with any vocal cord problems, temporary or permanent postoperatively. Hamid Jalilian, my neurotology colleague. Michael Mahonen, my pediatric neurosurgery colleague. This is Roselle Cow, my clinical nurse coordinator, who's been with me for over 9 years. This is Wendy Storm and Heather Corson, the two PAs who've been with me over the last 10 years. We have a whole separate team in the OR for the nursing, and I would not be able to do any of this without them. So we now have 14 minutes left for questions, so I wanted there to be plenty of time for discussion because this is complex and potentially confusing, and there's just not a lot of information out there that's published. This is the largest series by more than twofold ever evaluated, documented, and analyzed, and we're presenting this for the Facial Pain Association for the first time.
Thank you, Dr. Lenski, for an incredibly informative presentation. We have several questions from the audience. I would like to start with the first question that we hear frequently here. If somebody doesn't want to have an MVD for geniculate neuralgia, what other options are there? And what is the relative success or failure rate compared to an MVD that is done by an experienced neurosurgeon?
Well, that's a very good question with a very unfortunate answer. And that is that when it comes to cranial nerve 7 and nervus intermedius, the only options are open surgical with the exact same anesthesia and approach. It's just a matter of whether you do an MVD or a nerve section. Now, if you're lucky and you guess right, and the geniculate neuralgia is due to the trigeminal nerve, then any procedure that you would do for the trigeminal nerve will potentially take away the ear pain if it's trigeminally mediated only. The same is true for cranial nerve 9 and 10. Now, for cranial nerve 5, your options include one of 4 palliative destructive procedures, namely percutaneous radiofrequency lesion, percutaneous balloon compression, percutaneous glycerosotomy, or stereotactic radiosurgery with the gamma knife, or one of the other technologies that can approximate its results. For cranial nerve 9 and 10, your options are a little more limited and a little less successful. If you're lucky in guessing that the ear pain is due to cranial nerve 9 or 10, then fixing or treating cranial nerve 9 or 10 will potentially take it away. So one option would be to do the exact same anesthesia and risks of surgery, but section cranial nerve 9 or upper fascicles of cranial nerve 10. which we only do if MBDs have failed. You also can treat cranial nerve 9 and 10 with palliative destructive procedures. Radiofrequency lesion can be done for cranial nerve 9 or 10, but number one, it's not very successful compared to with the success for trigeminal neuralgia. And number two, it's dangerous because 9 and 10 run together, and effects of 10 from heating the nerves have an inordinately high amount of problems with dysphagia afterwards. And the vagal nerve mediation of electrical stimulation for the lesioning can have serious effects on the cardiovascular system and the heart. So if you're older or you have cardiac issues, that can be problematic. Gamma knife is the safer palliative destructive procedure for cranial nerve 9 and 10, but you're treating the nerve not where you want to be, near the brainstem. You're treating it at the jugular foramen, where it's not the root entry zone. It's peripheral Schwann cell nerve. And as a result, the success rate is not as great. So in the multi-institutional international trial for glossopharyngeal neuralgia, and only measuring success by being BNI class 1 through 3B, which is a very broad way of measuring success, because 3B is you're still having pain on meds. The success rate is only 63% at 1 year, dropping to 49% at 2 years, dropping to 38% by 3 years. So these are not the numbers you get with trigeminal neuralgia. And with trigeminal neuralgia, you're looking at being pain-free for typical neuralgic pain for 3 to 5 years in 80% of patients. That's not what you're getting if you use the jugular foramen as the target and you're treating cranial nerve 9 and 10 with radiosurgery. But those are options that can help, at least temporarily, in a minority of patients. They're just nowhere near as effective as a proper posterior fossa exploration of all 4 cranial nerves, sparing the nerves with the exception of nervus intermedius when at all possible, and only moving on to destructive procedures if that fails.
Thank you so much, Dr. Linsky. I have another question here. Can you discuss the relationship of GN and craniocervical instability in people who have suspected hypermobility syndromes like EDS, Ehlers-Danlos syndrome?
Ehlers-Danlos syndrome is related to cranial neuralgias, not through cranial cervical instability, but due to the effects it has on the connective tissue of the blood vessels. So, for example, if you look at our pediatric trigeminal neuralgia population, where we've got more than 100 patients with onset and surgery before age 18, 50% of them, by the time they're 21, will manifest Ehlers-Danlos syndrome. So it's a very predisposing connective tissue disorder for cranial nerve pain syndromes, not from a ligamentous cranial cervical instability standpoint, but from a ligamentous blood vessel laxity. Not ligamentous, connective tissue blood vessel laxity perspective, and possibly some cross biological interaction with the myelin pathways, where we don't really have that worked out. But in terms of the actual mechanical instability of the head and neck, I know of no connection.
Okay, thank you. That's very helpful. Here is a question. I'm going to show it up here on the screen. Is the pain in the masseoid area part of GN pain?
Well, as I showed you on those colored pictures of the ear, there's a little part of the auricle in the back that is innervated by cranial nerves 7 via nervus intermedius and cranial nerve 10. But the scalp itself in the mastoid area is not. That's the lesser and greater occipital or greater and lesser auricular nerves, depending on the terminology you want to use. And that's more than likely a manifestation of occipital neuralgia, which is not a cranial neuralgia at all. It's a somatic cervical branch peripheral nerve.
Thank you. Thanks for helping provide clarity there. I have another question from Monica here. Can you speak about the differences between eustachian tube dysfunction versus GN?
Yeah. So eustachian tube dysfunction can cause pain deep behind your eardrum because the pressure can be elevated in the middle ear, or you can just have pain from a dissociation between the pressure outside the eardrum and the pressure inside the eardrum. And that can lead to abnormal motions of the eardrum, which can be painful. The pain of eustachian tube dysfunction is usually able to be detected by a good neurotology evaluation, both by looking at the tympanogram, how does the tympanic membrane move, stressing it with different gusts of air and pressure changes, and even by responses to treatment to help keep the eustachian tube open in terms of decongestants, nasal sprays, things like that. So that's why for patients where we're not sure, all of our patients get evaluated by a neurotologist. That's one of the differential diagnosis issues that you have to rule out. You don't want to be going into somebody's posterior fossa and operating on 4 cranial nerves for eustachian tube dysfunction. That would be bad form.
Yes, not great care of the patient. Yes. Does deep ear pain mean at the eardrum or in the ear canal?
It can be either, but we place more weight towards pain that is deep beyond where a Q-tip can reach, either the very deep part of the external canal or the eardrum or opposite side of the eardrum. Those, when the pain is localized there, it's more likely to be geniculate neuralgia than one of the other lookalike differentials. But geniculate neuralgia can affect the external ear, and it can affect the external canal at a more superficial level. Remember those colored drawings I showed you where 3 nerves, cranial nerves, are innervating the external auricle and the external auditory canal. So cranial nerve 7 via nervus intermedius, cranial nerve 5 via the preauricular branch, and cranial nerve 10 via Arnold's nerve, all can contribute to that.
Thank you. Here's a question. What are the differences between auricular neuralgia and geniculate neuralgia?
Well, I guess it depends on who's using the terms. Remember the slide that I threw up at the beginning with all the different names? Auricular is just, you can substitute otalgic or otalgia. For the auricular just means ear. Okay, so episodic ear pain, episodic otalgia, primary otalgia, auricular neuralgia, these are descriptive terms for quote unquote ear pain. And all these terms are horrible because they lump everything together, and a descriptive term doesn't give you any insight into the etiology or what's causing the problem. And that has to be sorted out clinically between the neurosurgeon and the neurotologist.
Thank you. Megan asked a question. She said, I'm sorry if I missed it, but did you find a difference in success rate in surgical treatment of geniculate neuralgia versus TN patients?
A little bit, but not as much as you would think. Using our current paradigm, we can get patients to be pain-free for typical neuralgic pain in 69.2% of patients. With typical trigeminal neuralgia, we can do it in 80% or more. So it's a little lower than we can achieve with trigeminal neuralgia, but not that much. That's still far better than the results achieved with nervus intermedius sectioning alone, or any of the other things you might try, radiofrequency, gamma knife, palliative destructive procedures, or anything like that. Because remember, if you take away the typical neuralgic pain, if it's gone, then by definition, you've proven that the vascular compression was the cause. And since you've addressed the cause rather than just the symptom, you haven't just palliated the condition, you've potentially cured it. And so long-term results are much more likely in a successful MBD than in one of the palliative procedures. And the recurrence rate correspondingly is also much lower. But geniculate neuralgia is harder. You've got to be good at decompressing 4 cranial nerves, and you got to be good at doing it not only successfully, but safely. And the 7th, 8th cranial nerve complex in geniculate neuralgia has a 38% chance of having a blood vessel going between the nerves, which is very difficult to decompress. All you can basically do is move it out towards the IAC, and if it's a vein, sacrifice it, which is a little risky. And that's why we, even in our original paradigm, in that situation, would look for nervus intermedius and section.
Thank you. She did have a follow-up question, and I think this is good for everyone. Will this study be published somewhere where we can point our primary care doctors or neurologists to?
Well, that's certainly the goal, but right now I'm too busy taking care of patients and operating and to get this all published yet. But this was just analyzed for the very first time 11 months ago. And it's going in for abstract presentation at national meetings for 2025. And then I've got to fill that COVID follow-up hole to get the the life table analysis longer, farther out to show the durability of response, and then it'll be ready for prime time. Just like my redo MVD pattern of failure analysis, just like my pediatric MVD trigeminal neuralgia analysis, it's all got to be done. I wish I had, 3 fellows working with me. That would be nice.
Absolutely. Well, thank you for all that you do. We have time for one more question. Here is a question from Monica. You mentioned a link between palatal myoclonus and GN. Is there any evidence so far to indicate a link between other myoclonus events and GN, i.e. muscle spasms elsewhere in the body?
Palatal myoclonus is a muscular spasm from a specific cranial nerve that's also associated with the GN. It has nothing to do with muscle myoclonus elsewhere in the body, outside of the cranium. So it's not going to be related to the standard neurology myoclonus diagnoses. But for specific muscles, neurologists will call it myoclonus if it's a muscle spasm. So should you call it hemipalatal spasm? Should you call it hemivocal cord spasm? Should you call it spasmodic dysphonia? Should you call it laryngeal spasm? Should you call it palatal myoclonus? Depending on which doctor you're talking to and what their background and training is, they'll use similar terminology to describe the exact same thing. The key point is, if it's muscle spasms in a nerve that can cause geniculate neuralgia that also has a muscle component, then it's potentially related, just like geniculate neuralgia and hemifacial spasm are both 7th cranial nerve potentially.
Thank you so much. And thank you, Dr. Linsky, for today's excellent presentation on the microsurgical treatment of geniculate neuralgia.